Welcome to OzSAGE this 27th of September, Monday afternoon for our 3 o'clock presser. My name is Lisa Jackson-Pulver. I'm the Deputy Vice-Chancellor, Indigenous Services and Strategy at the University of Sydney. I'm also a Professor of Public Health and a Public Health Epidemiologist. I'm grateful that you're here today. I'd like to pay respects to the country that we're coming to you from and to all of the countries that you're coming to us from. There's not been a part of Australia that hasn't been known, loved and nurtured since time began. I pay respects to elders past, present and those emerging. So today you're going to hear OzSAGE advice on air quality and ventilation, Aboriginal and Torres Strait Islander health, the current stats and data and deaths at home, and finally advice on the ambulance system and the health and welfare of that service's staff. There'll be time for questions as usual. Please raise your hand or pop a question in Zoom chat and we'll do our best to answer those in order. If there is a specific recipient of your question, please name that person and we'll be happy to direct it to them. If you have any further media inquiries about today's conference, please direct those as usual to Amy Stevenson. That's amy.stevenson@sydney.edu.au. Today's conference will be, of course, recorded and will be made available on the OzSAGE website on ozsage.org. So, who is speaking today? Well, as usual, we have 4 speakers. Firstly is Distinguished Professor Lydia Masaka from the who wrote the WHO guidelines on air quality. Lydia has got another obligation straight after this, so we will take questions for Lydia straight after her talk. Followed will be PhD scholar Ebony Lewis, who will update us on Aboriginal and Torres Strait Islander health. Professor Guy Marks will follow and will speak to stats and deaths at home, and Professor Peter Amira will talk about the ambulance services. So, statistics as of today. I'll recap what we know. In New South Wales, there are 787 new cases, 12 deaths in the last 24 hours, 1,155 people are hospitalised, and of those, 214 are in ICU. We recognise that 85% of all New South Welsh persons have had their first dose of vaccine and 60% have had their second. In Victoria, 705 new cases, 1 death, 325 hospitalisations, 73 in ICU, 78% first dose and 47% of the Victorian population with their second dose. In the ACT, the nation's capital, we've got 18 new cases with 1 death in the last 24 hours, 8 hospitalisations. 86% of the population in Canberra have had their first dose, with 59% of their second dose. And in Queensland, we understand there have been no new cases in the last 24 hours, nor have there been any deaths. There are 7 people in hospital, none in ICU, and 63% of the population have had their first dose of vaccine. So I will hand over to Lydia, who will speak now about the WHO guidelines on air quality. And as I said before, questions to Lydia straight after. Thank you, Lydia.
Thank you very much, Lisa. So basically that's what I will be talking about the WHO organization air quality guidelines 2021, which were released last week on Wednesday. And in my short presentation, okay, so this is the topic of my presentation. And as I said, air quality guidelines versus standards, the guidelines which were just released, and best practice on ultrafine particles. So first of all, what's the difference between guidelines and standards? These two are often confused. So in general, air quality guidelines is any kind of recommendation or guidelines on the protection of human health or a sector in the environment from the adverse effects of air pollution. So this is just very general. Now, but when we are talking about WHO air quality guidelines, it is exclusively based on exposure-response relationship found in epidemiological studies, toxicological studies, environment-related studies, not restricted to numerical values, but can be expressed in a different way, but it's usually numerical values. So the most significant is that the only evidence taken in setting up the WHO guidelines is health, nothing else. So it's not economical, not any other consideration taken. Now, when it comes to air quality standards, it is a level of air pollution could normally concentration, but also could be expressed differently, the position, so which is promulgated by a regulatory authority and adopted as enforceable. So this is the point. WHO guidelines cannot be enforceable because WHO does not have authority over national jurisdictions, but it is the national jurisdictions which take advice from the WHO guidelines, and then based on this, they develop national standards. So this is the difference between the two types of documents. As we've seen over the years, national jurisdictions normally take into consideration WHO guidelines, and normally this is a very important piece of advice. Not, however, all the countries are able to set their standards at the level of the WHO guidelines. So this was a big development on Wednesday last week, when 2021 WHO guidelines have been released. They also included the best practice statements. This is new. Now, for me, it was a particularly important moment because I was a co-chair of the guideline development group, and the work was going for 5 years. So having this finalized and fruit of this work was particularly important. So this is how that's the cover of the new WHO guideline document, and these are the values. So first of all, the guidelines consider these 6 so-called classical pollutants. PM2.5, which is particulate matter smaller than 2.5 micrometers in micrograms per cubic meter, PM10 smaller than 10 micrometer, ozone, nitrogen dioxide, sulfur dioxide, and carbon monoxide. Very important in setting guidelines or standards is average in time, because we are talking about human exposure. So it is important, and the question is how long people are exposed to the specific concentrations. So as we can see, the values are either annual or 24-hour, but they could be also different for different pollutants, dependently on the impacts they have on health. Now, so if we look at the values starting from the PM2.5, which is considered one of the most significant risk to humans, as was assessed by the WHO work and also by global burden of disease studies. So PM2.5 is in globally number 4 risk out of all risks to which people are exposed. So here we have a comparison between the previous edition of the guidelines, 2005, and now. So it's been 16 years between these 2 documents. And as we can see, most of the values went down. So starting from annual PM2.5 was 10, now it's 5, 24 hours 25 is now 15, annual PM10 was 20, now it's 15, 24 hours 50, now it's 45. Now, ozone is a big difference because until recently, this was only 8-hour average in time, and this hasn't changed. But what has been added is concentration during the entire peak season, because ozone is particularly present and a risk during warmer periods when there's a lot of sunshine. Now, there's nitrogen dioxide, annual 40 in the previous document, now it's 10. Now, nitrogen dioxide is a pollutant emitted from combustion and specific from vehicles, specifically from diesel vehicles. So this signifies the importance of this pollutant, particularly in urban areas where there's a lot of traffic and a lot of human exposure. And 24-hour value was added. Now, the only difference is carbon dioxide. Here, the value actually now, new value is higher than the old value. This is because all the pollutants were assessed in exactly the same way before. It was they were assessed differently, and therefore it came up with a slightly higher value. And 24-hour carbon monoxide was added, and it is 4. So now you can ask a question, okay, what does it mean for Australia? And here are the same, it's the same table, but we have the last column added, and these are current Australian national standards. So starting with PM2.5, until recently, Australian standard was better, more conservative than the WHO, but it's not anymore because its value is higher than the WHO. And basically, as you can see, all the values are higher than the WHO for PM2.5 and PM10, which means that even if jurisdictions comply with Australian standards at the level of the Australian standards, they would not be meeting WHO guidelines. Now, it is a bit different here, more complicated when it comes to other pollutants, and this is because the averaging times in Australian standards are different than in the WHO guidelines. So therefore, we cannot directly compare this exposure. So this is in particular for ozone, when there's not for peak season, but for 1 hour, 8 hours versus 4 hours. So we would still need to do some assessment how it would relate, but direct comparison cannot be made. There's also one question you may ask, why the strange value specific 196 or 57? In the Australian standards, this is not expressed in micrograms per cubic meter, but in values ppm, parts per million. Now, we recalculated these values, taking some assumptions. We recalculated what it would be in micrograms per cubic meter for comparison. Now, so as you can see in relation to NO2, there's quite a big difference, even bigger with the other pollutants. Again, it's difficult to compare SO2 and carbon monoxide. So this is already, as you can see, a problem because of potentially not meeting the WHO guidelines, which means not having sufficient protection against the air pollutant. We didn't really have time yet to do proper assessment what it means in terms of comparing to the actual values of in different cities, in different areas. The point is that every city has numerous air monitoring stations, which means represent exposure of people in different areas. So we've just looked at a few states, and this is South East Queensland, and we looked for comparison at 3 years. 3 years because there was, as you know, a very significant event, the bushfires, which changed the situation quite significantly in terms of PM2.5, and we are talking about PM2.5 and 10. So if we look at this as annual here, and new annual WHO guideline is 5 micrograms per cubic meter, you can see that all these stations in Southeast Queensland exceed this value, and in 2019 they exceeded because of the bushfire quite significantly. There's also the number of exceedances. This is the relevant to the 24 hours. We don't know by how much they exceeded because this is just exceedance, but they did, which means that they will be exceeding even more. So this is the situation with air quality guideline values for classical pollutants. But for the first time, WHO also introduced good practice statements, and these are for black elemental carbon, ultrafine particles, and dust and sandstorm. And this is because it's been shown through epidemiological studies and other health-related studies that there are additional health impacts due to exposure to these pollutants, which are not represented sufficiently by the classical pollutants. However, for these pollutants, there's not enough health evidence to be able to develop numerical exposure response curves. So just mentioning ultrafine particles, best practice, because this is a most significant pollutant in terms of combustion, vehicle emissions and any other combustion. The sources of this pollutant, and by the way, the definition of these particles are particles smaller than 0.1 micrometer, which is quite significantly smaller than what we've talked previously, 2.5 or 10. And the significance of this is that these particles go very deeply to the respiratory tract So the sources are in urban areas where the majority of Australian population resides. Roads and other forms of transportation, aviation, shipping, and so on. So they are emitted directly from the sources, but they are also formed in the air from gaseous precursors, usually originated from these sources. So really it is combustion which is the problem here. Now, until recently, in the previous edition of the WHO guidelines 2005, there was this statement: while there's a considerable toxicological evidence of potential detrimental effects of ultrafine particles on human health, the existing body of epidemiological evidence is insufficient to conclude on exposure-response relationship to ultrafine particles, and therefore there was nothing else in the guideline document about this. There's been a lot of work done on this topic over the last few years, and I led this team, the team Thinking Outside the Box team, which consisted of exposure experts like myself, toxicology, epidemiology, and we generated this white paper, Ambient Ultrafine Particles Evidence for Policymakers, which is hosted by the European Federation of Clean Air and Environmental Protection Associations. So this work was used by the WHO in formulating the best practice statement for ultrafine particles. I will not talk about all the aspects of this, but just one aspect of this. We formulated here the so-called typical values. We don't have recommendations in terms of guideline values, but typical values based on the available evidence. And based on this, we are saying that the following daily 24 hours mean particle number concentrations, because that's how ultrafine particles are measured, can be considered as typical based on the scientific literature. Clean environments not affected by anthropogenic sources smaller than 10 to the third particles per cubic centimeter, in urban background, one order of magnitude higher. And a typical urban environments, and here is hourly means, concentration below 2 by 10 to the 4th particles per cubic centimeter. The significance of this is that since at the moment there are no reference or guidelines values for exposure to ultrafine particles, and therefore it's difficulty in designing standards, these values can be, the typical values can be used as reference and potentially in developing national approaches to this pollutant. So I'll stop here, and I'm happy to take questions.
Thank you very much. I've just asked people to either pop up their hands or to pop a question in the chat box. There was a question I received a little bit earlier, and it's about how this can, the information that you've shared and the knowledge and the work that you've done, how can this make our universities and other intense lecture spaces compliant with guidelines easily?
Well, this is a very, very good and important question, because while the concentrations and the guidelines values are general, but it's important to stress that they apply to both outdoor air and indoor air. As probably everybody knows, each state has already outdoor air monitoring and compliance checking, and if the values are not compliant with Australian standards, there are measures taken. However, in Australia, we don't have as such indoor air quality standards. In the Australian National Construction Codes, there are values of the pollutants, but there's no enforcement means, and there are therefore nothing is being done about this. So there's a big gap between what is being done in terms of managing outdoor air and what is not being done about managing indoor air in terms of air pollutants. So this gap will need to be addressed, and I must say that Australia is among the countries which don't have indoor air quality standards.
Thank you, thank you. Are there any other questions on this or other matters? Okay, so I'll ask the next obvious question to the first question, and that is, if we were committed to actually getting some standards for indoor air quality, how long do you believe we should allow ourselves a grace period before we get it happening?
By grace period, it's the implementation. There's always, if we introduce new legislation, there's always some grace period. There's always time when it takes effect. I wouldn't probably be guessing what is this time in this case. The most important, however, is that we start working on this now. Because if we don't start working on this now, nothing will happen. I probably would worry less that whether it's a grace period of 1 year or 2 years, the most important is that we start working on this. But there's one important other aspect of this. So we are talking about indoor air, but outdoor air has a very significant impact on indoor air. So if we have indoor air standards, but outdoor air is not controlled and it's not complying in compliance with the national standard, and the standards are not in compliance with WHO guidelines, so this outdoor air will still be affecting indoor air. Now, what needs to be done for Australia to get closer to the current WHO air quality guidelines? It is really energy transition to clean energies. Without this, we can't really achieve clean outdoor air, which means we can't achieve clean indoor air either. So this is a very important aspect.
It's a very, very logical response. Thank you very much. If colleagues don't have any other questions for now, thank you very much. It was good to hear you, and thank you very much for your presentation. So now, Ebony Lewis, PhD scholar, who will update us now on Aboriginal and Torres Strait Islander health. Over to you, Ebony.
Many thanks, Lisa. So I'm Ebony. I'm a Wiradjuri woman and researcher working in public health at the University of New South Wales. So I'm coming to you from Bidjigal country here in Sydney, and I want to pay my respects to elders past, present and emerging, and all Aboriginal and Torres Strait Islander people here with us today. So Aboriginal and Torres Strait Islander people were identified as a priority group since the COVID-19 vaccine rollout commenced earlier in the year. And Aboriginal and Torres Strait Islander people must not be left behind when restrictions start to lift in New South Wales. So there have been 2,550 Aboriginal and Torres Strait Islander COVID-19 cases since the start of the pandemic. And since the start of the New South Wales outbreak in June, there have been 2,405 Aboriginal and Torres Strait Islander cases, with 739 documented cases in the West and Far West New South Wales. Now, the good news is that in some of these areas of concern, which have recently experienced devastating outbreaks, such as in the Far West of New South Wales, vaccine coverage rates are increasing. And this has largely been attributable to ramping up the public health response and governments working closely with the Aboriginal community-controlled health sector to prioritise efforts to increase vaccine rates in these areas of concern. However, nationwide, vaccination data still reports around 20% lower vaccination coverage in Aboriginal and Torres Strait Islander people compared to the national average. So Australia-wide, as of the 21st of September, there were 46.6% of Aboriginal and Torres Strait Islander people aged 12 years and older who had received at least one vaccine dose, and 28.3% 12 years and older who are now fully vaccinated. And there's also variations with vaccine coverage across and within our states and territories. So in New South Wales, we know that in some Sydney areas, 50% of Aboriginal people have been fully vaccinated. However, other geographical areas, for example, the Mid-North Coast, vaccine coverage is much lower, with just over 25% fully vaccinated. The good news is that New South Wales, Victoria and the ACT are all on track to have over 80% first dose coverage of people aged 12 years and older. So New South Wales has released an updated roadmap today, and with plans to allow travel to regional New South Wales at the 80% target. But the lower vaccination rates for Aboriginal and Torres Strait Islander people and people in regional and remote regions pose clear risks for those who are not vaccinated. So more work needs to be done to close this gap, and a target needs to be set for the New South Wales roadmap of vaccination rates for Aboriginal people. Now, as vaccination rates among Aboriginal and Torres Strait Islander people still remain lower than the general population, and when restrictions are lifted, this can have a devastating impact on Aboriginal communities. In particular, Aboriginal communities in rural and remote areas we have seen have been at heightened risk. For example, in New South Wales far west, only just last month, the COVID-19 outbreak had spread to Wilcannia. And since Wilcannia outbreak, we've since had other outbreaks in other regional and remote communities across the state. And this has devastating consequences in terms of physical health, as well as impacting the social and emotional health and well-being of the person and the wider community. So we need to make sure that no one is left behind. Federal and state governments should provide the support necessary to ensure that vaccine targets are met for Aboriginal and Torres Strait Islander population, and that everyone across Australia has the opportunity to be vaccinated before the inevitable exposure that will occur when restrictions are lifted. So the Aboriginal and Torres Strait Islander OzSAGE working group recommends that at least 85% and preferably over 90% of Aboriginal and Torres Strait Islander people aged 12 years and over are vaccinated prior to New South Wales lifting restrictions. And this is to protect our Aboriginal and Torres Strait Islander communities, leaving no one behind. And this should be the target rather than 80% of 16 years and over as the New South Wales state average, before non-essential travel is allowed to remote and regional New South Wales. There have been calls from other states and territories, peak bodies and health leaders who have also called for high vaccination rates of 90 to 95% for Aboriginal and Torres Strait Islander people. And these include the Australian Indigenous Doctors Association and the Aboriginal Medical Service Alliance Northern Territory before relaxing restrictions and opening borders. And a high vaccination rate is important as the Aboriginal and Torres Strait Islander population has a relatively younger age structure than the wider population and living with more chronic health conditions, which increases the risk of serious illness and hospitalisation from COVID. And high vaccination will also help better protect our young children and the unvaccinated. Now, high vaccination rates are certainly achievable. So the OzSAGE working group also recommends that Aboriginal and Torres Strait Islander community health leaders and organisations are at the centre of decision making at every stage, and that governments continue to work with community leaders as efforts to supporting Aboriginal and Torres Strait Islander vaccine uptake is stronger when community led. So trusted community leaders and Aboriginal health organisations are really best placed to empower communities, address vaccine hesitancy that Aboriginal and Torres Strait Islander people may have. And this is due to factors such as colonial history, which has played a role in mistrust between Aboriginal people and governments, as well as COVID-19 vaccine misinformation, so such as discouraging Aboriginal and Torres Strait Islander people from receiving the vaccine. There's been particular concerns of misinformation being disseminated on social media platforms, and there have also been recent reports that some faith groups have been discouraging vaccine uptake, particularly in remote communities. And community leadership really plays a pivotal role in communicating culturally appropriate and tailored messaging for Aboriginal and Torres Strait Islander people about COVID, about vaccinations and protective measures to keep communities safe and strong. Now, we do know that further efforts will be needed, and this is possible with governments and Aboriginal leaders and organisations continuing to work together. There are known issues with health service gaps, with an immediate need being to address workforce staff shortages. And this is particularly important for regional and remote places here where healthcare services are already stretched. Additionally, as restrictions relax and borders begin to open, there is a need to increase health promotion efforts and face mask supplies within Aboriginal and Torres Strait Islander communities so people are aware of the risks. Now, going forward, additional modelling scenarios for vaccination rates, specifically for Aboriginal and Torres Strait Islander population for opening up and the potential impact of childhood vaccinations may be warranted. However, this will require assessments of the quality of Aboriginal and Torres Strait Islander data to ensure accuracy. Now, the OzSAGE Aboriginal and Torres Strait Islander Working Group recommends that any Aboriginal and Torres Strait Islander COVID data reported is comprehensive and disaggregated. And furthermore, disaggregated data on vaccine rates and Aboriginality could also help determine whether non-essential travel to remote communities should be allowed. Thank you.
Thanks very much, Ebony. We've got a couple of questions for you. Is it okay if I ask you those now? They're quite specific. One of them is, to reach an 85 to 90% target in communities, what are the concerted efforts that need to be made? I know you touched on that, but can you be a little bit more precise about what you believe is needed?
Yeah, well, definitely, I think a huge priority is addressing the health workforce. So actually having people on the ground, whether it's nurse practitioners, Aboriginal health workers, being able to put jabs in arms. We also need vaccine supplies, and certainly community-led health promotion to be able to address the misinformation that we are seeing, unfortunately, around social media platforms, and furthermore, other protective measures as well, such as affordability of face masks and those sorts of things.
Yeah, so it's quite a lot of different things that'll make all the world of difference. Just to follow that up, we've been asked, how long do you believe it'll take to get to that rate?
Yeah, well, I'm not probably the best person to ask. My area is not epidemiology, and I haven't done too much modelling. Lisa, I don't know if you want to comment on that or.
I can. Yeah, absolutely. I think one of the biggest things that we need to do is to do what it takes to get to those rates as quickly as possible. And I can't see why we can't have a hand in glove motion with the rest of New South Wales. So it's about bringing the whole population along, and OzSAGE is very much about leaving no one behind. Okay, Ebony, thank you. There's a few more questions that are coming through at the moment, but we'll get to those at the end. Now I invite Guy Marks to share with us the information that he's compiled for us. Over to you, Guy.
You're muted, Guy.
Am I now unmuted? Hopefully, yes. I just want to, first of all, acknowledge the traditional custodians on the land in which we meet today. I'm coming to you from Gadigal country, and pay my respects to elders past and present, and I extend that respect to Aboriginal and Torres Strait Islander peoples here today. And the slide that you can see here reminds us that the pandemic that we're dealing with at the moment is not the first pandemic which we've inflicted upon the Aboriginal people of New South Wales. And this is an example of an earlier pandemic brought by Europeans to Australia, which wreaked terrible havoc in Aboriginal people. So I'll stop sharing there. I think somebody has some slides for me to speak to on the statistics. Is that correct? Somebody going to share those slides?
Yep, the team's just popping them up now as we speak.
Okay, good. While they're coming up, I just wanted to just reflect a bit, just to go back briefly to what Lydia's presentation, and some of you in the audience may be wondering, why did we talk about air pollution at OzSAGE? And the reason is because somebody's asking me to share my own slides. Okay, I'll try. Well, just before I do that, I'll just say what I was going to say. The reason that we talked about air pollution is that it forms a continuum for us with the issue of protection against aerosol viruses such as COVID. And the underpinning concept is the concept that we all have the right to breathe safe air. And we've had, in fact, a number of examples of hazards, of airborne hazards that have been major problems for us recently. The COVID is the most recent. Last year we had the summer bushfires, when we, particularly in southeastern Australia, all had to take shelter indoors from an outdoor hazard from smoke. And those in Melbourne will remember that not that long ago they had a thunderstorm which inflicted severe episodes of asthma on people in that city. And in fact, many people were hospitalized, and about 10 people died due to asthma from this airborne threat. So there are numerous airborne threats to health, both indoor and outdoors, and we need to take this threat more seriously and ensure that as citizens in our country, we have a right to breathe safe air. So that's the link that links the issues around COVID to the issues around air pollution. And in fact, much of the learning that Professor Marasco was talking about in relation to ultrafine particles and small particles is exactly the same principles that apply to the aerosol spread of COVID and other respiratory viruses. And we're applying those same principles here. Okay, now I'll move on to talk about what I was actually asked to talk about today, which is these data, updated data on COVID. What you see on this slide is that reporting that over 10,000 reported community cases. The majority actually are in younger people. Just over half of them are in people aged under 30. And many of those, the data you can see in the bottom right-hand slide shows what we've seen is that the number of cases reported has now peaked and appears to be declining slowly. And this clearly is a benefit of the interventions that have been taken, both the ramping up of vaccination across the community and the maintenance for now of quite strenuous social isolation and social distancing. If I could go to the next slide. This is an analysis of what's called the doubling time. That is the period of time that it takes the number of cases in the community to double, the number of cases to increase twofold. The way to interpret this graph is that when the doubling time is decreasing, and you can see that here, it was decreasing, and here it was decreasing in Victoria, and here again, it was decreasing in Victoria. That means that, thank you. I think you can't see my arrow, but you can see somebody else's arrow there. You can see when it's decreasing, what that means is that the rate of increase in COVID is actually increasing. So a fall in the doubling time means that the rate of increase is going up more quickly, and that means we are losing control. When the doubling time increases, which it is now in New South Wales and the ACT, and also in fact in Victoria, that's a good sign. That means that the rate of increase in the number of cases is falling, and it's a sign that we are gaining control over the epidemic. So that is a good sign for us. Sorry, go on. Next slide. Yeah. In the past week, sadly, there have been a further 77 deaths that have been reported. These are the deaths and hospitalizations across the country, most in New South Wales and Victoria, as you can see, most in older people, but you can see that some of the deaths are occurring in people in their 40s and 50s. 5 of these deaths have occurred in people outside hospital who were being managed at home, and in some cases who were not diagnosed with COVID prior to their death. I think that's is that the last of the slides? I think so. Thank you. So that's all I had to say, but I'm happy to answer any questions about the epidemiology and the public health response.
Okay, we do have a question for you a bit later on vaccine passports, so we might hold off on that for now.
Sure.
So we'll hand over to Peter O'Meara and then we'll open up the floor to questions. So Peter, over to you.
Thank you, Lisa. I've been asked to, we're on the wrong slide here. That's better. I'm speaking today on behalf of the OzSAGE ambulance paramedicine group and the impact that COVID's having on the ambulance services. Like the rest of society, ambulance services have been put under tremendous stress with COVID, not just with the patients presenting, but the risk involved. And that's pretty central to what we're talking about. The first thing I need to say is that the ambulance services at state and territory level in Australia are very much a part of the health system, and they are working at full capacity and under great stress. Even before COVID, ambulance services were under tremendous stress in the large capital cities and large regional centres because of the change in workload due to ageing populations and so forth. So the stress is not new, it's just additional. The second thing to say is that paramedics are nationally registered health professionals, and they bring a broad range of capabilities in both emergency and primary care, and the latter is quite important. They work routinely in uncontrolled settings. That means they go into people's homes where they don't know what they're going to find, they've never seen the patient before, they don't know the family. They work at the roadside, which is what you see in the popular media, but it's very, very much an uncontrolled environment, and that's what really makes paramedics unique. There has been some research conducted, led by Charles Sturt University, which indicates that paramedics are under incredible stress and suffering very high burnout signs due to the COVID pandemic. And that's something we'll come to when we talk about some of the specific issues. The issues we identified as part of our investigations was that there is a growing demand for ambulance services because of COVID, and the complexity of care is a really major issue for paramedics. And it's been exacerbated by the types of presentations with COVID. And we can see that really with the emergency department ramping. Now, for those who don't know what ramping is, this is what you'll see outside an emergency department with a whole line of ambulances waiting with their patients. Now, there's been reports across Australia and internationally for that matter, with paramedics and ambulances waiting outside emergency departments with their patient for hours. I'm talking 4 or 5 hours. That's pretty terrible for the patients, and it's not at all good for the paramedics. And as a result, there's likely to be adverse events from one, waiting to get into hospital, but also there's adverse events emerging outside the hospital because ambulances are actually stuck at hospitals and their crews and not able to respond appropriately and in a timely manner to emergencies outside. So you'll see news reports of people having cardiac arrests and not seeing an ambulance for 25 minutes, people having babies or obstetric emergencies. It can be anything. It's not just about COVID. It's that flow-on effect that's affecting ambulance services and paramedics so much. The other big issue we identified was the protection of the safety and well-being of the staff in these uncontrolled settings. Now, personal protective equipment, like masks and gowns and gloves and all that sort of thing, are designed for use in hospitals. They're not particularly designed for ambulance service use over extended periods of time. When they're normally used it's only for short periods of time. Now, paramedics are increasingly working in PPE through their whole shift. That's extremely exhausting, and it's only going to get worse as the weather gets warmer. The other issue that's related to that, and it's very much related to the earlier talk about ventilation. When ambulances are ramped at a hospital, they're not moving, and the ventilation is designed for a moving ambulance, an ambulance that has its motor on. So if you're sitting in an ED and you have the patient on board who might or might not have COVID, you can't very well run the air conditioner, and you can't run the vehicle without causing problems for the emergency department and all the people around it. So that's a problem that needs to be solved. The other I've already mentioned about the evidence of rising staff stress and burnout. Staff are really worried about their own safety, the safety of their family. And I guess from my point of view, it's very reassuring to know that paramedics are also concerned about doing a good job, and they find it very difficult to do a good job under the circumstances that are presented to them. And that's really measured in things like the mortality rate from cardiac arrest, for instance. And we did a survey 12 months ago, and we thought, oh, I wonder if the perceptions are right, that this is all going to affect cardiac outcomes. Well, the staff were right. The data shows that the survival rate from out-of-hospital cardiac arrest has deteriorated during COVID. And this is a finding that's been found all over the world. The third issue we've identified is that ambulance services don't have a great deal of infection prevention and control expertise. And what they do have isn't amongst the paramedics particularly. It's not to say people aren't any good at their job. They're very good at their job. It's just that this is an unprecedented disaster that has really tested the capabilities of ambulance services. The final issue is that paramedic scopes of practice are a bit antiquated, and they really don't match their professional capabilities. Now, one example is their limited deployment as vaccinators. Paramedics give a wide range of drugs by various means in their day-to-day jobs, but they've not easily been deployed to be vaccinators. And remembering that not all paramedics work in ambulance services. 25% of the registered paramedics in Australia don't work for the ambulance services. They work elsewhere. And many of them are underemployed, and they could be used in that sort of setting. We'll come to that later with the recommendations. We've recommended a number of changes that could be considered. One is to address ramping through having external emergency department triage and holding areas. That is tents and things like that, just so that the ambulances can hand over their patients, get back to being available for other emergencies. Their other issue that is really a problem for the paramedics is that when you do have a COVID patient or one is suspected, you end up having to clean the ambulance and restock it completely. And that takes hours and hours. Enormous use of the workforce and a lot of time. And what we're suggesting is that there be people organised to actually clean the ambulances for the paramedics, restock them, and give the paramedics some time off because they're working under great stress. So the two could be combined. So that might have a hub somewhere near a hospital so that they can get back to their work. Third is to deploy paramedics better to utilise their capabilities and availability. Now, an example of that, which Ebony touched on, was going out and doing vaccinations in rural and remote areas. This has been done in Canada, where paramedics have been tasked into really strike forces, if you like, who've gone into First Nations communities. They've flown in and they've actually vaccinated enormous numbers of people in remote Canada who don't have access to primary health care. So if people want some information on that, I can give it to them. The fourth point under system changes is that there should be a national regulatory body to oversee and implement these recommendations. At the moment, because our ambulance services are organised by jurisdiction, they don't necessarily coordinate terribly well. Furthermore, to the paramedic safety and wellbeing, crews need to have adequate recovery time, and that includes debriefing. It's a very stressful experience to be exposed to an infectious disease, and nurses, doctors all go through the same things. Ambulance services need to prioritise some strategies to ensure the physical and mental wellbeing of their staff. They could consider rapid antigen testing, which I'm sure will be covered elsewhere by OzSAGE. Appropriate PPE needs to be designed and introduced that actually will stand up to the rigours of an out-of-hospital environment, and also the fact that people are in them for a long time and can't just go and have a break. There's nowhere to change for a start in an ambulance. And finally, ambulance design needs to be looked at to bring the ventilation up to hospital standards. Paramedics are undertaking aerosol producing procedures without the advantage of good ventilation, and that's potentially dangerous. So these are some of the areas that need to be looked at in our view. And thank you.
Thanks very much, Peter. That's quite fulsome and I think quite sobering. So it's great your advice is going up on the OzSAGE webpage shortly. Is that right?
That's right.
Absolutely fantastic. So we'll direct everybody to have a good look at that. We do have a number of questions for our panellists. Firstly, on the question of vaccine passports. And according to our requester for an answer to this, Liam Mannix from The Age and the Sydney Morning Herald, he states these are essentially state-sanctioned discrimination between people who are vaccinated and those who are not. Some communities have much lower vaccination rates than others, and this may split along the lines of disadvantage or for other reasons. The question is this: how will we know some groups who have lower vaccination rates than others? Is there a risk that vaccine passports will end up not just discriminating against people who do not vaccinate, but also against those people who may have other disadvantages in life? So I'll start with Guy on that one. Over to you, Guy.
Well, I think it's a good question. And I think it highlights the importance of ensuring optimal access to vaccination for everyone. So vaccine passports will only work when we have optimized the accessibility of vaccines and broken down all of the barriers that there are. And we've heard about that at the moment with Indigenous populations. We know, of course, that there were many delays in getting the vaccine rollout. And going in Australia, it is now moving at a fast pace. But until we have ensured that everybody has access to vaccinations, there will be inherently disadvantage for people who are not vaccinated. The main disadvantage will not be that they're not permitted to do certain things, but that they're at greater risk of acquiring COVID and having the severe consequences of severe COVID. That's the reason to ensure access. The broader question around mandates, whether it's for vaccines or for masks or for public health measures, is also, I think, an important question to address. And there's been a lot of debate around this over a long period of time. And the reality is that we do need to there are competing rights here. There is the right of individuals to make decisions for themselves, but the competing right is the right for individuals to be protected from public health threats. And I come from the field of tuberculosis. I just came from my TB clinic to this press conference now. And in relation to TB, there is a very strongly held view amongst Australians that they want to be protected from the risk of acquiring TB. And that if there is a case of TB in the community, they expect the public health authorities to protect them from acquiring TB. And it's the same for other public, other infectious diseases. There is an expectation in the community, and this comes back to what I was saying about safe air, that we have safe air to breathe and that we're not at risk of acquiring infectious diseases. So all of the mandates, all of the public health restrictions that exist to try and guarantee that. We need to balance these things. We need to balance the restrictions that we impose on people to make sure that they're only those that are required to actually protect others. We should not do excessive restrictions, but people do have a right to be protected. And that's where the balance lies. The other thing I would just say around vaccines and the requirement for this relates to our health service. At the moment, the health service is frankly creaking at the seams. And this is not really an issue for healthcare workers. It is an issue for healthcare workers, but the main issue is in fact for patients. The main issue is that many patients who require care in our health system are not getting the level of care, and we heard about this in ambulances, but it's across the whole health system, are not getting access to the sort of care for cancer, for heart disease, for strokes, and all those sort of things that they would require, because much of the hospitals are full of unvaccinated patients who are sick with COVID. Now, the hospitals are there to treat those patients, and it's not those patients' fault. But the only way in which to save our health system so that it can perform its other functions is to vaccinate people so that they're not at risk of having severe outcomes and requiring hospital care. This has been the experience all around the world, and it's now the experience in New South Wales. So there are a number of reasons why we need to do this.
Yeah, and they're compelling. You know, what you've said is compelling. I know we have another question here, which I think is a really important one to at least get a chance to answer. And that is, would understanding deaths at home in the data help show disparity between those who are resourced and those who are not resourced?
Possibly. I mean, I can't, deaths at home due to COVID is at least just a function of the fact that there are deaths. So when the more COVID cases that we have, and the more COVID cases that we have in people who are unvaccinated in particular, the more risk there will be of patients dying due to COVID. And the more cases of deaths due to COVID that there are, some of those will inevitably happen in people who are either delay in diagnosis and therefore not having access to care, or who've had some failure of transition from the home care environment to the hospital environment. Yes, we can try and, there may be failures in those transitions that we can overcome, and some of them may relate to better delivery of care for underserved populations. And yes, we could learn that by understanding more about it.
Thank you very much. Thank you very much to our panellists for today's presser. Thank you very much to all of those of you who have come in. Again, amy.stevenson@sydney.edu.au for any further questions. Please have a look at the the OzSAGE website for all of our latest information, particularly that of our ambulance colleagues, Peter Amira, Guy Marks, Ebony, and of course, all of you. Thank you very much for coming. We'll see you again. But one thing I must say, we will not be having a presser next Monday, but we will have having one the Monday following. So please stay safe and well until then. Goodbye.